Well, thank you very much, Harry, and thank you very much to all the organizing committee for this invitation. I like the title, Why We Should Be Careful Using Nuke Discontinuation as a Therapeutic Option. So very challenging title. These are my disclosures. I will try to cover the issue of nuke discontinuation in clinical practice, as well as nuke discontinuation very briefly in clinical trials. I will not cover the issue of nuke discontinuation when you achieve S antigen loss, because this is standard of care. I will only cover the issue of nuke discontinuation before S antigen loss, and only in the setting of patients without any evidence of cirrhosis, as is currently recommended by guidelines. So why do we want to stop nuke before achieving S antigen loss? On the left side, you see all the reasons why you should not stop. Excellent therapy, easy therapy, improved survival, overall very cheap and very easy to be managed, long-term suppressive therapy. On the right-hand side, some possible reasons why you would like to stop before S antigen loss. I will basically cover the last issue, which is, can we stop before S antigen loss to achieve S antigen loss? That would be a strategy which has been suggested. And this is really the summary of the sort of strategy that we highlighted a few years ago together with Thomas Berg in this editorial. So overall, here we are including several studies and many years of activities. Basically, you have three different phases. You start from the left side, a stable situation on therapy. Everything is easy to be managed on therapy, PCR negativity, normal LT. Then you stop oral therapy, you enter the second phase, where basically characterized by instability. You start to increase DNA, ALT, potentially go high, and this phase will continue with different really clinical situations for 1 year, maybe 2 years. And then the last part on the right side, you have, again, a sort of stable condition, which corresponds to the long-term outcome with different rates, with different results according to the population, to the clinical setting, to the studies, and so on and so on. So why do I think this is a challenging situation? First of all, because of the endpoints. So the question is, what is the endpoint of this nuke stopping therapy? For you as a doctor, for you as a patient potentially. So this is something that we have to define before stopping therapy. It's not easy. Which is the endpoint? S antigen loss, inactive cardiac state, normal health therapy, or no treatment, or no retreatment? This is something that is very difficult to be defined before you stop. You have to talk with your patients. And timing, of course, is also relevant. For example, look at these two studies. On the right-hand side, the Toronto STOP study. On the left side, the FINAT study from Germany. And you look at the S antigen levels, S antigen loss. On the right-hand side, Toronto, I think there was one single patient who achieved S antigen loss over 45 patients. On the left side, you see the German study, for 10% of the patients achieve S antigen loss. So even if you achieve S antigen loss, it will be a very rare event. And according to whether you live in Toronto or in Germany, they would probably be very different, and probably because of different genotype, the antigen status, Asian ethnicity, and so and so. Well, if you change the endpoint and you go for HPV DNA, well, which is the best strategy? Continue therapy or stop therapy? Well, if you continue therapy, there will be very super good results, 99.9% suppression. If you stop therapy, everybody will relapse. Again, probably with different kinetics, comparing Toronto study and the FINAT study. And what's about ALT again? We all agree ALT normalization is important. The only way to achieve full suppression of normal ALT is to continue oral therapy. If you stop, significant flares in both studies, again, probably even more relevant in the Toronto study compared to the German study. Well, your endpoint could be retreatment. So no retreatment could be potentially a good endpoint, not from my point of view. But what is the probability that you have to restart therapy? 40% in Greece, 40% in Germany, 38% in Canada, 41% in Taiwan. So very similar across the studies. 40% will restart therapy, so 60% will probably remain without therapy. That does not mean PCR negative or with normal LT, for sure. But there is another issue which makes this strategy very complicated, is timing of retreatment. On the left side, you see a study from Taiwan, a large study looking at the probability of S-antigen loss over time after nuke discontinuation. And please look at the group A and group B. What is the difference? Group A, they had a clinical relapse and they received early rescue, no S-antigen loss. Group B, clinical relapse without early rescue, yes, 18% of S-antigen loss of therapy, statistically significant. So the message from the study is that, yes, you are not too early retreatment, but at the same time, not too late to avoid severe flares. Again, this is very complicated in clinical practice, super complicated. What about predictors of response? And that's another issue which is relevant. We don't have strong predictor of response. This is a very nice study from UK, Kosh Agarwal group. They look on the right-hand side, trying to predict not S-antigen loss, not PCR negativity, but just flares. On the right-hand side, 4 patients had a severe flare of therapy, more than 10 times upper limit to normal. The only two predictors were high HBV RNA levels and high correlated antigen levels. No difference in terms of S-antigen levels. But this is a super small study, never been prospectively validated to my knowledge. What about S-antigen levels? Again, this has been already mentioned, a very nice study, 13% S-antigen loss of therapy over 48 weeks. But the probability of achieving S-antigen loss is only confined to specific patients. White patients with S-antigen levels below 1,000, Asian patients with S-antigen levels below 100. But not all these patients will achieve S-antigen loss. And please remember, the Caucasian patients were very, very few in this study. And this is retrospective study. I don't think has been prospectively validated. If you change study, the number will change again. In this very large study, retrospective, mainly Asian study, well, the best predictor S-antigen below 10, 5% of the population only. If you go for high S-antigen levels, you need correlated antigen. And then even in these 10% of the overall population, retrospective study, not all these patients will achieve S-antigen loss. So this is a very difficult to use strategies over time. What about flares? Again, we already covered this issue in parts. Significant flares following DNA rebound, potentially different in the Toronto study compared to EU studies. What about the good flares? What about the bad flares? Right-hand side, well, technically speaking, you should make a differential diagnosis by looking at the S-antigen kinetics at the peak of ALT. Beneficial means S-antigen goes down at the peak. Bad flare means S-antigen goes up at the peak. Well, but that's very complicated in clinical practice. This is very nice, a nice study retrospectively. I will challenge you to make this definition on a real live clinical practice. And sometimes things can go wrong. I know MF already alluded to this case. This is a nice case from, well, it's not a nice case, but that's an interesting case from the RIF2 study. 54 years old male from Hong Kong, probably genotype B or genotype C, has been on therapy for 10 years on TDF, very good fibroscan, very low DNA, very low S-antigen levels, randomized RIF2 to no therapy, which is good probably. And he was on TDF for 1 year, he very low S-antigen levels, normal T, negative DNA, and then he stopped TDF, the first kind of green arrow. And then he had initially almost nothing, but already a significant DNA increase. And then the situation got wrong very, very, very rapidly. He was lucky. He was in London. He got a liver transplant. Rescue therapy was not successful. So be careful. This was a case enrolled in a randomized controlled trial. And I got this information a couple of days ago from J&J. It was HBV RNA negative at the end of therapy, but 4 logs of core. You cannot stop in NUC in these patients, which is not typical for e-antigen negative. This is typical for actually e-antigen positive patients. What's about the management of these 2 strategies? This is a sort of personal simulation. If you randomize someone to continue oral therapy on the left side or to stop oral therapy, well, that's a lot of work. That's a lot of monitoring. That's a lot of tests you have to ask, check, and make a decision on. Very complicated. And look at the lower part. You need a super good doctor, a super good expert center, a very good compliant patients. So this strategy cannot be used to improve hepatitis B functional cure in Asia, in Africa, in South America, where you cannot even use long-term oral therapy. So in my view, there are 2 strategies. Strategy number 1, let's go for S antigen loss on therapy, during whatever is the drug you want to use, NUC or new therapies, and confirm S antigen loss of therapy. Strategy number 2 is much more complicated. I would not go for a strategy which requires NUC discontinuation or drug discontinuation, new drug, to achieve S antigen loss of therapy, specifically if this requires significant ALT flares. But there are some special situations, new situation. Again, I'd like to mention again this study from the REEF-2 study. On the right-hand side, you see the ALT profile of patients who stop NUC without anything else versus those patients who stop NUC after 1 year of siRNA and CAM. And actually, the ALT profile is completely different, even though the DNA profile is different, but not completely different. And if you look at the lower part of the slide, right-hand side, 35% of the patients who stopped NUC before antigen loss had a significant ALT flare, compared to only 3% of those who were, let's say, pre-treated somehow with siRNA and CAM. I don't know the mechanism. Maybe CAM is not relevant. Maybe siRNA is relevant. The difference is also S antigen levels were lower in the second group compared to the lower one. Therefore, but this is potentially opening a new avenue, a new strategy. One issue is the long-term outcome. Let's do everything we can to improve the long-term outcome. But another possibility, which is new, is also try to improve how we get to the final outcome. So basically new strategies to improve, optimize how to reach the favorable outcome. For example, making the off-treatment management much easier, much safer. So in conclusion, ladies and gentlemen, dear moderators, I think in selected non-cirrhotic antigen negative patients, discontinuation of NUC before antigen loss is possible. But this strategy, is very complicated. It's very complicated. It's not applicable in most of the centers. You see all the reasons that we already mentioned. So in general, in my view, new antiviral therapy should aim to achieve antigen loss during therapy and use the off therapy only to consolidate. And however, new treatment strategies may eventually suggest new possibilities to simplify NUC discontinuation. And if you really need an ALT flare, because your drug will require ALT flare, make sure these flares are mild, short-lasting, predictable, and associated with high rates of functional cure. Thank you very much.